Hi everybody, my name is Theo Bistes. I'm a vascular surgeon in Münster, Germany. Thank you for watching this short tutorial about planning of an endovascular abdominal aortic aneurysm repair. In this chapter, I'm going to present you the most important steps of the planning in order to choose the right devices for your procedure and to have a successful outcome. First of all, keep in mind to stay always inside the instructions of use in order to achieve the best outcome for your patient. Here is an example of IF use for the Endurant device. You can see that you have to have an proximal neck diameter between 19 to 32 millimeter, the neck length, and more important, the infra and suprarenal angulations play an important role. The diameter of the aortic bifurcation should be more than 20 millimeter. The iliac and femoral axis should be friendly for your implantation. The iliac diameter, and of course, you have to implant your devices on a distal fixation length more than 15 millimeter. Having the IFU in your mind, you can now start with your planning and sizing. The first step is to assess the quality of your CT scan. That means try always to work with 1 millimeter thickness in order to have exact measurements of the different distances, but also in order to be sure that you have not missed, for example, small structures like an accessory renal artery. Moreover, use if possible a center line and do not make your planning in axial CT images. Why? Because the axial CT images, they have several limitations. First of all, the images are not perpendicular to the vessel, and the elliptical cross-sections lead sometimes to imprecise diameter measurements. Keep in mind, narrow diameter of the elliptical cross-sections are more consistent with true diameters. In my opinion, the most important step is to draw the aneurysm in a sheet of paper. This strategy has several advantages, which, believe me, will change your daily practice with the treatment of abdominal aortic aneurysms. You have to document your planning in a way that it is reproducible. This is important if there is a delay between planning and implantation. You can document important anatomical issues like calcifications, dissections, thrombus, stenosis. This is crucial because you may forget such important details on the day of implantation. There is only one time that you are really focused on the measurement and planning of the abdominal aortic aneurysm, and this is always the first time of your planning. Third, you receive directly a feeling about the anatomic challenges of the aneurysm, like angulation, type of neck, access vessels, tortuosity, etc. So let's go through an example of a AAA. You can appreciate in this image that we are writing the first name and surname of the patient, when the CTA happens and takes place. You see that we have different diameters, lengths, and on the left side, the devices that we are going to implant. On the bottom, you see the name and the date of the planning. The first drawing represents an abdominal aortic aneurysm with a straight neck and a friendly anatomy. First of all, you have to write the date of the patients with name and date of birth, as well as the date of the CT angio. These details are important in order to have a direct access on such information during the admission of the patient. Keep in mind, the drawing should include all important information in order to have all in one document before implantation. Moreover, your sign and the date of measurement are important for everybody in order to know when was planned this procedure and who is responsible for this planning. The second important issue is to prepare your puncture site. This includes the location of the deep femoral artery in association to the femoral head. This is important to assess the exact height of your puncture under fluoroscopy and to prevent any accidental puncture of the deep femoral artery during percutaneous EVAR. Here is also important to describe any challenges like thrombus, dissections, calcification, or stenosis. The third important issue is to measure the distances and the diameters at different levels of the aortic aneurysm. Start always by the proximal neck. In this specific case that I have already shown, the supra and infrarenal angulations do not play a relevant role because we are talking about a straight neck. You are starting measuring the diameter below the lowest renal artery and then you are going up to 10 millimeter. In our case, we have a very friendly anatomy. You see 23 millimeter very proximal neck, 24 and then again 23. The total length is 23 millimeters. However, based on the diameters and angulations across the neck, you may have different types of proximal necks which may challenge your EVAR procedure. These are a straight neck, like in this case, an angulated neck, here you have to check the angulations according to the eye of view, a tapered neck, you have to oversize based on the diameter below the renal arteries, a reversed tapered neck, be careful for adequate oversizing based on the biggest diameter, 15 millimeter directly below the renal arteries. Finally, there is the bulge neck, which will be carefully assessed if this could be a criterion to go for a fenestrated or chimney endographing, and the short neck. We have now a CE certifications for EVAR for short necks, but this remains still controversial. However, it is not an issue of this tutorial. The next important distance that you have to assess is the distance between the lowest renal artery and the aortic bifurcation. Following anatomical scenarios and issues should be taken under consideration. Do you have enough space for the contralateral limb? Do you may have any challenges with the catheterizations according to the morphology of the aneurysm? What about the distal neck diameter? Is the diameter more than 20 millimeter? In that case, you have always to consider if you have a very short distal neck, actually an exclusion criterion according to the eye of view, you may try to use an EVAR, but in that case, try to use balloon expandable stents in kissing balloon technique. The final step will be to measure the distance and the diameters of your distal landing zone and your access vessels. You have to measure from the aortic bifurcation up to the origin of the hypogastric arteries. Then you have to add the diameters of the common iliac artery and to find the ideal zone for landing with your limb. The length should be at least 15 millimeter. However, this depends on the eye of view of its device. Keep in mind that in case of long, healthy common iliac arteries, you have not to stent the total length of the vessel. In this context, you have to carefully draw now any relevant issues regarding the delivery of your endograft. This is an example of possible types of drawing for those anatomic challenges. For example, an elongated external iliac artery, or even a very short common iliac artery, or a stenotic external iliac artery, a dissection at the level of the common iliac artery, an occluded hypogastric artery, a previous petsplasty of the common femoral artery, or a previous stenting. All these anatomical scenarios or anatomic challenges may lead to a poor outcome with your EVAR if you are not taking consideration of them. In cases that you have to go up to the hypogastric arteries, sometimes it may be difficult to rotate the C-arm in such view in order to see exactly the origin of the hypogastric artery. But in your CT scan, you can rotate the aneurysms in the 3D reconstructions in different views to see which one is the best for the origin of the hypogastric arteries. In that case, just inform yourself by drawing the exactly LAO or RAO position in order to use it directly during your intervention. This plan can lead only to success, because here we have information about accessory renal arteries that have to be covered. We have information about stenosis and calcification at the level of the common iliac artery, some problems with the morphology of the aneurysms when we are going to open the contralateral gate of the EVAR device. We have to be careful here because the deep femoral artery is relatively high, and we have to go through a petsplasty of the common femoral artery. Before closing this first chapter of our tutorial about the principles of planning on EVAR, I would like to remind you the 6 P's of success. And these are: proper preoperative planning prevents poor performance. Thank you for your attention, and keep tuned at Vascupedia. The second chapter about the sizing of the right tendograph will be uploaded very soon. You will be informed by our social media channels or in our official website. Take your pencil, take a sheet of paper, and try to do your first measurements. And do not forget, you can comment on this video or ask any questions in our forum below. See you soon, and bye.